Yes, a very good morning to all of you. A very good morning to all of you. Yes, am I audible to all of you? Please add in the box. Please add in the box. Am I audible? Yes, a very good morning. Suresh, Mohit, Nitesh, Jitendra. Am I audible? Please write. Hope you all are safe at your home. Yes? Okay. Let's start with today's topic, that is disorders and hormonal control of carbohydrate metabolism. This topic, disorders of carbohydrate metabolism, include diabetes mellitus, ketosis, bovine ketosis, pregnancy toxemia, hypoglycemia in baby pigs, hyperinsulinism in dogs, and it also includes hormonal control of carbohydrate metabolism and biochemistry of some digestive disorders or diseases. So this is slightly a long topic. Am I audible? Please add in the box. Am I audible? As I told earlier that today's topic is disorders and hormonal control of carbohydrate metabolism. Okay. It includes various disorders of carbohydrate metabolism like diabetes mellitus, ketosis, bovine ketosis, hyperinsulinism, then pregnancy toxemia, and also include hormonal control of carbohydrate metabolism and biochemistry of some digestive disorders or GIT disorders. So you all know the sources of blood glucose and the utilization of blood glucose. So you can see here sources of blood glucose. Dietary carbohydrate, you all know first source is dietary carbohydrate from diet, starch, sucrose, glucose, and then digestion and absorption, and then goes to liver. Second source is via glycogenolysis in muscle through lactate, and then amino acids, glycerol and propionate from breakdown of proteins and fats, and then they go to liver, and in the liver gluconeogenesis occurs. So please add in the box what is gluconeogenesis. Please add in the box what is gluconeogenesis. Am I audible? Am I audible to all of you? Yes, what is gluconeogenesis? Please add in the box. Synthesis of glucose from non-carbohydrate substances like lactate, amino acids, glycerol, and propionate. Okay. So first source is dietary carbohydrate. Second is by gluconeogenesis through glycogenolysis in muscle and by the degradation of proteins and fats. Okay. Third source of blood glucose is glycogenolysis in liver. It means, what does it mean? Please add in the box. Glycogenolysis, what does it mean? Yes, it means glycogen converts into glucose or breakdown of glycogen into glucose. Very good. So here, fasting sugar approximately 70 to 100 milligram per dl, controls by hormonal regulation, and some excrete into urine. So post-prandial or after meal, this will be 120 to 140 milligram per dl. Here we can see the utilization of blood glucose. It utilizes by glycolysis. You all know by PCA cycle, ultimate product of glucose oxidation is CO2 and H2O. You all know. Second is glycogenesis in the liver and kidney. So what does it mean, glycogenesis? Please write in the box, what is glycogenesis? It is the synthesis of glycogen from glucose. So glucose is utilized here. Synthesis of other monosaccharides and amino sugars. Okay. It also utilizes in HMP shunt for pentose, you all know, and for the formation of NADPH. Lastly, it is also utilized in or for the synthesis of various fats or lipids. So these are the sources of blood glucose. This is the pool, and these are the methods of utilization of blood glucose. Now it is clear to all of you. Please add in the box dietary source, gluconeogenesis, and glycogenolysis. All create the source for blood glucose, or all the sources are blood glucose. And these are the methods of utilization of blood glucose, like glycolysis, PCA cycle, glycogenesis, synthesis of other monosaccharides, amino sugars, HMP shunt for pentose and NADPH, and synthesis of various lipids. So our main emphasis is on the hormone that is called as insulin, which is very important hormone for the metabolism of carbohydrates, or for the regulation of metabolism of carbohydrates. So here, these are the type of metabolism. These are net effects and effect on some important enzymes. Most important is carbohydrate metabolism. First metabolism or cycle is glycolysis. Net effect of insulin is increased glycolysis. You can see here increase glucokinase, phosphofructokinase, pyruvate kinase, or increase in the concentration of these three enzymes. By this, net effect of insulin is increased glycolysis. Next, gluconeogenesis, it will decrease. Pyruvate carboxylase, phosphoenol pyruvate carboxylase, glucose 6-phosphatase, all are increased. So ultimate effect is decrease gluconeogenesis. Third is glycogenesis. Obviously increase, because increase in the concentration of glycogen synthase enzyme, the most important enzyme for the glycogenesis. And vice versa, glycogenolysis is decreased because of the decreased concentration of glycogen phosphorylase, the main enzyme for glycogenolysis. HMP shunt increased because there is an increase in the concentration of glucose 6-phosphate dehydrogenase. Second most important effect on lipid metabolism. Insulin effects on lipid metabolism. First is lipogenesis, means increased lipogenesis because of the increased concentration of acetyl coenzyme A carboxylase. It decreases lipolysis. This is the important feature. It decreases lipolysis. Insulin decreases, or insulin leads to decreased lipolysis because of the decreased concentration of hormone sensitive lipase, and it also decreases ketogenesis because of the decreased concentration of HMG coenzyme A synthetase. Little effect on protein metabolism, somehow increases protein synthesis and decreases protein degradation, means it is anabolic in nature via the increased concentration of RNA polymerase enzyme and decrease transaminases and deaminases. So this is the another way which shows the effects of insulin on animals. You can see here anabolism. This insulin increases anabolism, increase food intake, increase respiratory coefficient. In blood, it decreases glucose, ketones, fatty acids, phosphate, potassium, amino acids, ketone bodies, enzymes. These are increased, these are decreased, as I said earlier. In the liver, glucose oxidation, glycogen synthesis, lipid synthesis, protein synthesis are increased, and insulin decreases glucose production and ketogenesis. In the muscle, you can see here, skeletal muscle, it increases glucose uptake, glucose oxidation, glycogen synthesis, amino acid uptake, protein synthesis, potassium uptake. And in the adipose tissue, it increases glucose uptake, glycogen oxidation, lipid synthesis, and potassium uptake. So now, is it clear to all of you? The main effect of insulin is, this is hypoglycemic in nature. You have to remember this line, this is hypoglycemic in nature. So this is the hormonal regulation of blood glucose. You can see various hormones here. First and foremost hormone is insulin, another glucagon, epinephrine, thyroxine, glucocorticoids, and growth hormone and ACTH. So please write in the box, what is the molecular weight of insulin? Please write in the box, what is the molecular weight of insulin? And how many amino acid it contains? Insulin contains how many amino acids? Yes, its molecular weight is 5734 and it contains about 51 amino acids. Total 51 amino acids. Okay, 51 total. And its half-life is 4 to 5 minutes. And the gene is responsible for the synthesis of protein for insulin is on the chromosome number 11. It is present on chromosome 11, you all know. So this is the most important hormone, that is insulin. You can see here, I said earlier that this leads hypoglycemic effects. Overall effect is hypoglycemic. It means lowers the glucose in blood. Hypoglycemic effect. You can see here by various means like increased glucose uptake, increased glycolysis, increased glycogenesis, increased HMP shunt, increased lipid synthesis, increased gluconeogenesis, decreased gluconeogenesis, and decreased glycogenolysis. So it means insulin decreases gluconeogenesis and glycogenolysis and increases glycogenesis. So overall effect is it converts into glycogen by glycogenesis. So overall effect is hypoglycemic effect. Is it clear to all of you? Please write in the box hypoglycemic effect of insulin. By insulin, glucose uptake increases, glycolysis increases, glycogenesis increases, HMP shunt increases, lipid synthesis increases. As I said earlier, you can see here, it increases glycogenesis and it increases glycolysis, then glycogenesis. Insulin is hypoglycemic in nature. It means it leads to low glucose in blood because it converts all the glucose into glycogen via glycogenesis. So overall effect is hypoglycemic, and other mechanism also contributes in this feature, like increased glucose uptake, glycogenolysis decreases, gluconeogenesis decreases, and then HMP shunt increase, glycolysis increase, and glucose uptake and glycogenesis increases. What are the effects of hormones like glucagon, epinephrine, thyroxine, glucocorticoids, and growth hormone and ACTH? You can see here just reversal of insulin is the effect of glucagon. Gluconeogenesis increases. Here you can see gluconeogenesis decreases by insulin. Here you can see glucagon via glucagon, gluconeogenesis increases, and glycogenolysis also increases. So these two effects, gluconeogenesis and glycogenolysis, increase by glucagon hormone, and here you can see gluconeogenesis and glycogenolysis are decreased via insulin. So overall effect of insulin is hypoglycemic, and overall effect of hormones glucagon, epinephrine, thyroxine, glucocorticoids, growth hormone and ACTH are only one, that is hyperglycemic effect of all these hormones. You have to remember one thing only: insulin is the only hormone which is hypoglycemic in nature, and all other hormones are hyperglycemic. All are hyperglycemic: glucagon, epinephrine, thyroxine, glucocorticoids, growth hormone and ACTH. Now it is clear. Then Ramlal Tandi, now is it clear to all of you? You have to remember only one thing, that is insulin is hypoglycemic in nature, and glucagon, epinephrine, thyroxine and all other hormones are hyperglycemic in nature. Please add in the box, Ramlal. Have you understood the whole process or effects of these hormones like insulin, glucagon, epinephrine, thyroxine, glucocorticoids and growth hormones? Am I audible to all of you? Please write in the box. Am I audible? Yes? Okay, okay. Some people are writing. Okay. I am not audible. Okay, okay. Yes, I am audible. Okay. So you have to remember one thing which is most important, that is insulin. The effect of insulin is hypoglycemic, and the effect of other hormones like glucagon, epinephrine, thyroxine, glucocorticoid is hyperglycemia, or they are hyperglycemic in nature. Okay. Now, have you understood? Please write in the box. Have you understood? These are the blood glucose levels in some domestic animals. You can see here in millimole per liter, milligram per dl. Horses, cow, you can see 45 to 75 milligram per dl, sheep 50 to 80, 50 to 75 in goat. In dog, it is important, 65 to 118. So these are the important glucose transporters involved in the transport of glucose. First, GLUT1 glucose transporter 1. It is present mainly in brain, kidney, colon, placenta, erythrocytes. The main function of this GLUT1 is glucose uptake. It is commonly present. Second is GLUT2 or glucose transporter 2. It is mainly present in liver, pancreatic beta cells, small intestine, kidney, and it is responsible for rapid uptake or release of glucose. Likewise, glucose transporter 3, it is mainly present in brain. It is also responsible for uptake of glucose. The main or most important glucose transporter is glucose transporter 4. It is mainly present in heart, skeletal muscle and adipose tissue. And this is the important feature, that it is insulin stimulated glucose uptake, or it leads to insulin stimulated glucose uptake, or it stimulates the insulin dependent or insulin stimulated glucose uptake. Glucose 5, glucose transporter 5, it is present in the small intestine, and it is responsible for absorption of fructose and glucose. Another important sodium dependent unidirectional transporter, that is SGLT1, is present in small intestine and kidney, and it is responsible for active uptake of glucose against a concentration gradient. It is present in small intestine and kidney. So you have to remember this GLUT4, glucose transporter 4, which is responsible for insulin stimulated glucose uptake, mainly present in heart, skeletal muscle, and adipose tissue. So the most important disease is diabetes mellitus, or this is the main important disorder of carbohydrate metabolism. What is diabetes mellitus? Diabetes mellitus is a syndrome with disordered metabolism and inappropriate hyperglycemia due to either deficiency of insulin secretion or a combination of insulin resistance and inadequate insulin secretion to compensate. Or we can define it: diabetes mellitus is a metabolic chronic disease, more appropriately a disorder of fuel metabolism with disturbances of carbohydrate, fat, protein metabolism, means all the three metabolism, carbohydrate, fat, and protein, resulting from defect in insulin secretion, insulin action or resistance, or both. It is mainly characterized by hyperglycemia. You all know that leads to several long-term chronic complications. The effect of diabetes mellitus include long-term damage, dysfunction, and failure of various organs. So main important disease of carbohydrate metabolism or disorder of carbohydrate metabolism is diabetes mellitus. So here you can see major metabolic alteration in diabetic patients or in diabetes mellitus. You can see here, as I told in the previous slide, it is because of due to either a deficiency of insulin secretion or combination of insulin resistance or inadequate insulin secretion to compensate. Means there is a lack of insulin in the diabetic patients. Insulin is present in the lower concentration. You can see here, by this lower insulin, you can see major biochemical changes. Glucose uptake by tissue decreases, plasma amino acids increases, gluconeogenesis increases, glycogenolysis increases, lipolysis increases. So overall effect is hyperglycemia, or the increased concentration of glucose by the increased production of glucose or by the increased uptake of glucose. You can see here. And by this lipolysis, increased lipolysis, you can see here formation of ketone bodies, and it leads to ketoacidosis. Likewise, increase in the concentration of triglycerol synthesis, and this leads to hypertriglyceridemia. So overall effect, hyperglycemia, ketoacidosis, and this increased concentration of this TG triacylglycerol or hypertriglyceridemia. Now it is clear to all of you, these three effects. Please write in the box the major metabolic alterations in diabetes mellitus. Please write in the box. Have you understood these three? Hyperglycemia, overall increased production of glucose, production of ketone bodies, ketoacidosis, and this increased production of this triacylglycerol TG. Please write in the box. Have you understood the whole process? Because you saw in the slide that insulin, the metabolic effect of insulin is increased glycogenesis. Increased glycogenesis means when insulin is lower, then it decreases glycogenesis, or you can see increased gluconeogenesis and increased glycogenolysis. Just reverse. You can see in this slide, it decreases glycogenolysis and gluconeogenesis. Just opposite to it, you can see they are increasing. Okay, so overall effect is the increased concentration in glucose, or it leads to hyperglycemia or hyperglycemia. Second is the more production of ketone bodies that leads to ketoacidosis, and the third one is hypertriglyceridemia. Sign and symptoms of diabetes mellitus: you can see increased thirst, frequent urination, unexpected weight loss, increased fatigue, blurred vision, numbness and tingling, especially in feet and hands. It means सुन हो जाना और झंझनाहट हाथ पैरों में, feet and head में, and then slow healing sores, red swollen tender gums, skin itching or itchy, or more irritability. These are the signs and symptoms of diabetes mellitus. You can also see by this slide lethargy and stupor, smell of acetone, weight loss, hyperventilation, nausea, vomiting, abdominal pain in more common are present in more common in type 1. These blue are present more commonly in type 1 diabetes. We will discuss it later. So these are the main symptoms of diabetes: polydipsia, polyphagia, lethargy, stupor, eyes, blurred vision, weight loss, smell of acetone, hyperventilation, nausea, vomiting, abdominal pain, polyuria, and most important, glycosuria. So what is the status of diabetes mellitus in animals? Although diabetes mellitus has been reported in virtually all laboratory animals like gerbil, guinea pigs, hamsters, mice, rats, non-human primates, but in horses, cattle, sheep, and pigs also it is present. It is most frequently found in dogs and cats. So diabetes mellitus has been reported in these lab animals and horses, cattle, sheep, and pigs, but it is most frequently found in dog and cats. Estimates of incidence of diabetes ranges as high as 1:66 for dogs and 1:800 for cats. Am I audible? Dear students, am I audible to all of you? Please write in the box. Have you understood a little bit about diabetes mellitus? Okay. So we will discuss types of diabetes mellitus or classification of diabetes mellitus. Type 1, it is also known as IDDM. Type 2, NIDDM, gestational DM, or other type of DM, neonatal DM, and MODY. What is MODY? Maturity onset diabetes of the young. And this gestational diabetes mellitus is present in pregnant women. Pregnant women, it is present gestational diabetes mellitus. So, two types of diabetes are mainly present. First, type 1 and type 2. We will discuss in detail. First is insulin dependent diabetes mellitus, IDDM. IDDM, also known as type 1 diabetes. Juvenile onset diabetes mainly occurs in childhood, particularly between 12 to 15 years age. It is juvenile onset diabetes. IDDM accounts for about 10 to 20% of the known diabetic patients. This disease is characterized by almost total deficiency of insulin due to destruction of beta cells of pancreas. You have to remember only one cause, that is almost total deficiency of insulin due to destruction of beta cells of pancreas. Which cell secretes insulin? Please write in the box. Which cells secrete insulin hormone. Okay, beta cells. Good. The beta cells destruction may be caused by drugs, viruses, and by autoimmunity. Due to certain genetic variation, the beta cell are recognized as non-self and they are destroyed by immune-mediated injury. Usually, the symptoms of diabetes appear when 80 to 90% of the beta cell have been destroyed. The pancreas ultimately fails to secrete insulin in response to glucose ingestion. Fails to secrete insulin. The patients of IDDM require insulin therapy. This is the only way of treatment, insulin therapy. You can see here the etiology of diabetes, type 1 diabetes mellitus. You can see immunological factors, genetic factors, environmental factors. Then it leads to destruction of beta cells of pancreas. You can see here pathophysiology of diabetes mellitus type 1, virus, infection, alteration of cells, then autoimmune responses, destruction of beta cells, insulin deficiency, and this causes type 1 diabetes mellitus. This is the mechanism of action of insulin. You can see here this plasma membrane, this outside and this is inside. You can see insulin receptor inactive, this is active receptors. This is insulin hormone, this is glucose. You can see by active insulin receptor, process of signal transduction, gene expression, and growth regulation, and this is the utilization of glucose. By this glucose comes into the cell. By outside, you can see glucose comes comes inside. Second type of DM is non-insulin dependent diabetes mellitus. This is NIDDM. NIDDM, also called type 2 diabetes, adult onset diabetes, is the most common occurring or accounting for 80 to 90% of the diabetic population. Please remember, this is less severe than IDDM and this occurs in adult usually above 35 years. The positive factors of NIDDM include genetic and environmental. NIDDM more commonly occurs in obese individuals. Overeating coupled with underactivity leading to obesity is associated with development of NIDDM. So obesity acts as diabetogenic factor. Please remember, obesity acts as diabetogenic factor and leads to decrease in insulin receptor on the insulin responsive or target cells. The patients of NIDDM may have either normal or even increased insulin levels. Recent research findings on NIDDM suggest that increased level of tumor necrosis factor DTNFD and resistin and reduced secretion of adiponectin by adipocytes of obese people cause insulin resistance by impairing insulin receptor functions. So this is mainly due to the various factors, genetic and environmental. Obesity acts as diabetogenic factors. Please remember, this is less severe than IDDM. This is pathophysiology of type 2 DM, genetic predisposition, obesity, lifestyle factor. You can see this lifestyle factor. This is predisposition factors, genetic and environmental. This genetic and this insulin leads to insulin resistance, compensatory beta cell hyperplasia occurs, then beta cell failure, and this lead to impaired glucose tolerance. First normoglycemia, then impaired glucose tolerance, and lastly diabetes. This is the pathophysiology of type 2 DM. What is the difference between these two diabetes mellitus? First is insulin dependent diabetes mellitus and another is non-insulin dependent diabetes mellitus. can see here prevalence 10 to 20%, 80 to 90% type 2, age childhood, adults, body weight normal, is obese, genetic predisposable mild or moderate, and this non-insulin dependent very strong. Biochemical defects, insulin deficiency due to destruction of beta cell, here in type 2, impairment in the production of insulin by beta cell and or resistance of target cell to insulin, plasma insulin decreased or absent, normal or increased. Auto antibodies frequently found, rare. Ketosis very common in type 1, there it is rare. And then acute complications, ketoacidosis is present in type 1, and here it is hyperosmolar coma. Clinical symptoms, you can see duration of symptoms here, weeks, months to years. Diabetic complications at diagnosis rare, and administration of insulin, you can see always required, and here usually not required. So this is the comparison of these two type of diabetes mellitus, which is insulin dependent diabetes mellitus, and another is non-insulin dependent diabetes mellitus and IDDM. Now, have you understood the types of diabetes mellitus? And this is a very important slide. Short note is important for your examination, and long question also. Long-term effects of diabetes mellitus. Hyperglycemia is directly or indirectly associated with several complications like atherosclerosis, retinopathy, nephropathy, and neuropathy. It is believed that at least some of them are related to microvascular changes caused by glycation of proteins. So we can diagnose diabetes mellitus in the laboratory by various means. First is urine analysis, detection of glucose urea or glycose urea by Bendix and Felling test. You all know a specific and conventional method to detect glucose urea is the paper strip impregnated with glucose oxidase enzyme and a chromogen system, which is sensitive to as little as 0.1% glucose in urine. Another way, detection of ketone urea. You all know qualitative detection of ketone bodies can be accomplished by nitric oxide test, Rothera's test, etc. And third one is microalbumin urea. Albumin excretion rate intermediately between normally 2.5 to 25 milligram per day, and macroalbumin urea 25 milligram per day. So microalbumin urea is a common finding in type 2 diabetes mellitus and is a risk factor for macrovascular or especially coronary heart diseases or macrovascular diseases. So these three, glucose urea, ketone urea, and microalbumin urea. Please remember three methods: detection of glucose urea, detection of ketone urea, and this microalbumin urea for the laboratory diagnosis of DM or diabetes mellitus via urine analysis. Second is by blood biochemistry or serum biochemistry, blood glucose estimation. First, there are various means: fasting blood glucose, random blood glucose estimation, and glucose tolerance test. We will discuss this glucose tolerance test in detail, GTT. Second is by glycated hemoglobin HbA1c measurements, serum fructosamine estimation, and lastly by serum lipids. So these are the means for blood biochemistry of diabetes mellitus by blood biochemistry. Blood glucose estimation, glycated hemoglobin measurements, serum fructosamine estimation, serum lipids. Third, immunological assays, antibodies to insulin as red cells or glutamic acid decarboxylase GAD can be estimated to differentiate between the types of diabetes mellitus. They are absent in type 2 diabetes mellitus. Please remember, these antibodies are absent in type 2 diabetes mellitus. latent autoimmune diabetes of adults, or you can say LADA. Latent autoimmune diabetes of adult is a form of slow onset type 1 diabetes that occurs in middle-aged, usually white adults, and can be differentiated from type 2 diabetes by measuring anti-GAD65 antibodies. So what is glucose tolerance test? The diagnosis of diabetes can be made on the basis of individual response to oral glucose load. The oral glucose tolerance test, it is called as OGTT. What is the methodology of this GTT? Glucose tolerance test should be conducted preferably in the morning, 9 to 11 a.m. A fasting blood sample is drawn and urine collected. The subject is given 75-gram glucose orally dissolved in about 300 milliliter of water to be drunk in about 5 minutes. Patient should be in an overnight fasting state. We should take care that patient should be in an overnight fasting state. Blood and urine samples are collected at 30 minutes interval for at least 2 hours. All blood samples are subjected to glucose estimation, while urine samples are qualitatively tested for glucose. We have discussed previously. So, OGTT, oral glucose tolerance test. Interpretation of GTT, you can see here. Plasma glucose concentration millimole per liter or milligram per dl. In the case of normal human being, you can see here the concentration of glucose. In the case of impaired glucose tolerance and the case of diabetes, you can see here. In fasting, it is less than 110, 126, and in the case of diabetes, it should be greater than 126, and after 2 hours after glucose administration, you can see here in the normal patient lesser than 140, in impaired glucose tolerance lesser than 200, and in the case of diabetes or diabetic patient, it will be greater than 200 milligram per dl. So the fasting plasma glucose level is 75 to 110 milligram per dl in normal persons. On oral glucose load, the concentration increases and the peak value is reached in less than an hour, which returns to normal by 2 hours. In individuals with impaired glucose tolerance, the fasting as well as 2-hour plasma glucose levels are elevated, and a person is said to be suffering from diabetes mellitus. The fasting plasma glucose exceeds 7 millimole per liter or 126 milligram per dl. You can see here, and after then 2 hours, you can see it will be greater than, or it will greater than 200 milligram per dl. You can also interpret by these diagrams. You can see here oral glucose tolerance test, either here plasma glucose in milligram per dl, the time half hour, 1 hour, 1.5 hour, and 2 hours. In the case of diabetes, this is present like this. In the case of impaired glucose tolerance, you can see, and in the case of normal. So you can see here, the case of diabetes reaches to 250 and then lowers. You can see after 2 hours or at 2 hours, it will be greater than 200 milligram per dl in the case of diabetes. So please write in the box, have you understood the GTT, the whole mechanism of GTT, OGTT? Please write in the box. Please write in the box. Am I audible? Yes. Jitendra, Muskan, am I audible? Have you understood the whole process? Diabetes mellitus, what is diabetes mellitus, classification or types of DM, and the GTT, the various diagnostic methods for DM. Important one is GTT. Okay. Himanshu, am I audible, Himanshu? Supriya, am I audible? Kiran, Mayank, Abhilasha, Lalit, Ishan. Okay. Have you understood? Supriya? Nitesh Chaudhary? Have you understood, beta? Okay. Ishan? Okay. What is the management of DM? The various methods for the management of DM or the major components of the treatment of diabetes are first diet and exercise, oral hypoglycemic therapies, or another is insulin therapy. There are three means: diet and exercise. We can say dietary control, oral hypoglycemic therapy, medicinal treatment, or third is insulin therapy. So diet, exercise, drugs, and finally insulin are the management option in diabetes. Approximately 50% of the new case of diabetes can be adequately controlled by diet alone. 20 to 30% need oral hypoglycemic drugs, while the remaining 20 to 30% require insulin. First is dietary management. A diabetic patient is advised to consume low calories, low carbohydrate and fat, and high protein and high fiber rich diet. Fat intake should be drastically reduced so as to meet the nutritional requirement of unsaturated fatty acids. Diet control and exercise will help to a large extent obese non-insulin dependent diabetes mellitus patients. Another managemental aspect is hypoglycemic drugs, use of hypoglycemic drugs. The oral hypoglycemic drugs are broadly of two categories: sulfonylureas and bivinites. The latter are less commonly used due to their side effects. Sulfonylureas such as acetohexamide, tolbutamide, and glibenclamide are frequently used. They promote the secretion of endogenous insulin and thus help in reducing blood glucose levels, so they are hypoglycemic in nature. Management with insulin: two types of insulin preparations are commercially available: short acting and long acting. The short acting insulins are unmodified and their action lasts for about 6 hours, and the long acting insulins are modified ones and acts for several hours, which depends on the type of preparation. The advent of genetic engineering is a boon of diabetic patient, since bulk quantities of insulin can be produced in the laboratory. We can produce by genetic engineering. This is the important aspect of diabetes mellitus, or biochemical indices of diabetic control for a diabetic patients. So what are the biochemical indices of a diabetic control for a diabetic patients? First is glycated hemoglobin. You all know this is the major indices or important indices of this diabetes mellitus. Glycated or glycosylated hemoglobin refers to glucose-derived product of normal adult hemoglobin. Among the glycated hemoglobin, the most abundant form is HbA1c. You have to remember this HbA1c. HbA1c is produced by the condensation of glucose with N-terminal valine of each chain of hemoglobin A. Normally, HbA1c concentration is about 3 to 5% of the total hemoglobin. In diabetic patient, HbA1c is elevated as high as 15%. Determination of HbA1c is used for monitoring of diabetes control. HbA1c reflects the mean blood glucose level over 2 months period prior to its measurement. In the routine clinical practice, if the HbA1c concentration is less than 7%, the diabetic patient is considered to be in good control. So it should be less than 7%. Another biochemical indices are fructosamine. Besides HbA1c, several other proteins in the blood are glycated. Glycated serum proteins, that is called as fructosamine, can also be measured in diabetes. Likewise, microalbuminuria. Microalbuminuria is defined as the excretion of 3 to 300 milligram of albumin in urine per day. It may be denoted that microalbumin represent an immediately stage between normal albumin excretion and macroalbuminuria. This microalbuminuria serve as a signal of early reversible renal damage. Please Remember, microalbuminuria serve as a signal of early reversible renal damage. Another biochemical indices is serum lipid or concentration of serum lipids, determination of serum lipids, total cholesterol, HDL. What is HDL? Please write in the box. What is HDL? What is HDL? Please write in the box. What is HDL? And this triglycerides, TG. What is HDL? High density lipoprotein. Serve as an index for overall metabolic control in diabetic patients, and serum lipid should be frequently measured. Second disease is, or disorder of carbohydrate metabolism, is hypoglycemia of baby pigs. It is present in baby pigs. Hypoglycemia of baby pigs occurs during the first few days of life and is characterized by hypoglycemias of 40 milligram per dl, apathy, weakness, convulsion, coma, and finally death. The newborn baby pig is particularly susceptible to hypoglycemia. At birth, the blood glucose level is 110 milligram per dl, and unless the pig is fed or suckles shortly after birth, its blood glucose drops rapidly to hypoglycemic level within 24 to 36 hours. The liver glycogen, which is high at birth, is almost totally absent at death. In contrast, newborn lambs, calves, and foals are able to resist starvation hypoglycemia for more than weeks. But in this baby pigs, you can see pig is fed or suckles shortly after birth, its blood glucose drops rapidly to hypoglycemic level within 24 to 36 hours. If the baby pig suckles, its ability to withstand starvation progressively increases from the day of birth. A 10-day-old baby pig can be starved up to 3 weeks before symptoms of hypoglycemia occurs. Glyconeogenic mechanisms are undeveloped in the newborn pig, which indicates that the gluconeogenic enzymes of the baby pig are inadequate at birth. This also indicates that these enzymes need to be induced by feeding so that they can reach their maximum activities within 1 or 2 weeks after birth. You can see this hypoglycemia is present in this baby pigs during the first few days of life and is characterized by hypoglycemia, apathy, weakness, convulsion, coma, and finally death. Next is hyperinsulinism in dogs. Hyperinsulinism in dogs, it is known to be due to persistent hyperactivity of pancreas as a result of insulin secretion or insulin secreting islet cell tumors. Excess insulin can be excited from metastatic foci in liver as well as from the pancreatic tumor. There are many reports on the disease in dogs. It is mainly present in dogs, hyperinsulinism in dogs. Hyperinsulinism is characterized by a persistent hypoglycemia. You can see here hypoglycemia is also present. You can see here this hypoglycemia of baby pigs, and in case of hyperinsulinism, it leads to hypoglycemia. Hyperinsulinism is characterized by persistent hypoglycemia with periods of weakness, apathy, fainting, and during hypoglycemic stress, convulsion, and coma. The symptoms are also led by glucose administration. So you can see here by this hyperinsulinism or the increased concentration of insulin, it leads to the condition hypoglycemia. Now, is it clear to all of you that hyperinsulinism is, will lead to hypoglycemia? Why is it? Why it is so? Hyperinsulinism lead to hypoglycemia. Why is it so? Yes, please write in the box. Hyperinsulinism will lead to hypoglycemia. Why it is so? Please write in the box. What is the main function of insulin? Please write in the box. What is the main function of insulin? Yes, insulin converts glucose to glycogen, and another is increased uptake of glucose. So in blood, it will reduce or it may cause hypoglycemia. Now is it clear to all of you? Because all the glucose converts into glycogen and there is increase of uptake of glucose. Next is ketosis. You all know about ketosis. Ketosis is a state the body goes into if it needs to break down body fat for energy. The state is marked by raised level of ketone bodies in the blood. You all know what is ketonemia and what is ketonuria. Please write in the box what is ketonemia and what is ketonuria. So in the combination of these two, ketonemia and ketonuria is called as ketosis. You all know. If there is not enough glucose present, the body will resort to an alternative strategy in order to fuel itself. So if there is not enough glucose present, body will break down body fat for energy and it leads to increase or raised level of ketone bodies. What is bovine ketosis? Hypoglycemia is such a consistent finding in bovine ketosis and in bovine pregnancy toxemia. It is also important in this case of the case of pregnancy toxemia. In ovine, hypoglycemia is present. This hypoglycemia has played an important role in ketosis as a rationale for therapy and as a basis for the concept of ketosis. Pregnancy toxemia as manifestations of a carbohydrate deficiency which occurs under condition of excessive demands. In the case of pregnancy, you can see where there is an excessive demands of carbohydrate. Bovine ketosis, on the other hand, occurs in the high-producing dairy cow. Please remember, it is present in high-producing dairy cows, characteristically during the early stage of lactation, when milk production is generally the highest. Abnormally high levels of ketone bodies, acetone, acetoacetate, beta-hydroxybutyric acid, and isopropanol appear in blood, urine, and in the milk. So, ketonemia and ketonuria are present. The clinical signs of ketosis accompany these alteration, loss of appetite, weight loss, decrease in milk production, and some nervous disturbances. The energy metabolism of the ruminant is focused on the utilization of the volatile fatty acids produced by rumen fermentation rather than on carbohydrate as in non-ruminants. Bovine ketosis occurs in high-producing dairy cow, as I said earlier, during the early stage of lactation. Then abnormally high level of ketone bodies, acetone, acetoacetic acid, and beta-hydroxybutyric acid, and also isopropanol appear in blood, urine, and milk. And then you can see here hypoglycemia, starvation is a common finding in bovine ketosis and in the ovine pregnancy toxemia. In non-ruminants, liver is the sole source of ketone bodies. In ruminants, the rumen epithelium and mammary glands are also sources of ketone bodies production. Among the ketone bodies, acetone does not ionize to the appreciable level, whereas acetoacetic acid and beta-hydroxybutyric acids will ionize readily. Acetoacetate and beta-hydroxybutyrate are more powerful acids than the volatile fatty acids. Ketosis in the condition of lactation. You can see during lactation, plasma glucose is drained for the synthesis of lactose by the mammary gland. So here, plasma glucose is drained for the synthesis of lactose. The two sources of plasma glucose are absorption from the gut and gluconeogenesis. In ruminants, little glucose is absorbed from the gut. Most of the glucose is synthesized in the liver and in the kidney. The chief substance are propionate, which is produced in high grain diet. So here you can see during lactation, plasma glucose is drained for the synthesis of milk or lactose by the mammary gland. When there is a mismatch between mammary drain of glucose for lactose synthesis and gluconeogenesis in liver, hypoglycemia will result. Please understand this paragraph. When there is a mismatch between mammary drain of glucose for lactase synthesis or for the production of milk and gluconeogenesis in liver, hypoglycemia will result. This condition lead to ketosis. When hypoglycemia will result, then it leads to ketosis or the formation of ketone bodies by the, you can see, by the degradation or breakdown of fat for energy. Hypoglycemic theory of ketosis. The most widely accepted theory of bovine ketosis is hypoglycemic. During lactation, mammary gland might withdraw glucose from the plasma more rapidly than the liver can supply it, which leads to hypoglycemia. The hypoglycemia will lead to ketonemia as more of the long-chain fatty acid will reach the liver and oxidize or break down. The net result of this is an increase in the level of ketone bodies in blood. We can say ketonemia, and in urine we can say ketonuria, and the combined effect is ketosis. Laboratory test for ketosis. Rothra's test, you all know, is used as qualitative test for ketone bodies. The test is more sensitive for acetoacetic acid. Acetone gives only a slight response, whereas beta hydroxybutyric acid is insensitive to this test. Please remember, this beta hydroxybutyric acid is insensitive to this test. A number of drugs having keto-aldehyde, sulfate hydrogen groups, phenylketones, acetaldehyde, etc. can also react with nitric oxide and can give false positive result. Other tests for the laboratory diagnosis of ketosis are Ross test and cow side tests. Please remember Rothra's, Ross test and cow side test. So, complication of this diabetes mellitus or ketosis, we can say this ketoacidosis. Ketoacidosis is a metabolic acidosis due to excessive blood concentration of ketone bodies. You all know ketone bodies are released into the blood from the liver when hepatic lipid metabolism has changed to a state of increased ketogenesis. It is characterized by ketonuria. You all know loss of potassium in the urine and fruity odor of acetone on the breath. Please remember, these are the characteristic features. It is characterized by ketonuria, loss of potassium in the urine, and a fruity odor of acetone on the breath. Untreated ketosis may progress to ketoacidosis, and death. This keto condition is seen in starvation, occasionally in pregnancy, if the intake of protein and carbohydrate is inadequate, and most frequently in diabetes mellitus. So it is most frequently present in diabetes mellitus. Different type of ketoacidosis are diabetic ketoacidosis, that is also known as DKA. Due to lack of insulin glucose uptake, metabolism by cells is decreased. And another is starvation ketosis. Starvation leads to hypoglycemia as there is little or no absorption of glucose from intestine, and also due to depletion of liver glycogen. So there are two types of ketoacidosis: diabetes ketoacidosis and starvation ketosis. What is diabetes, or what is diabetic ketoacidosis? DKA is a state of inadequate insulin levels resulting in high blood sugar and accumulation of organic acids and ketones in the blood, and it is potentially life-threatening complication in patients with diabetes mellitus. It happens predominantly in type 1 diabetes, but it can also occur in type 2 diabetes mellitus under certain circumstances. Next topic is digestive disorder or gastrointestinal diseases of ruminants. First, we will take the digestive disorder of ruminants. First is acute rumen indigestion. When the animals consuming roughages are overloaded with readily fermentable carbohydrates, high concentrations of lactic acid accumulate in the rumen and subsequently in the blood. So there is accumulation of lactic acid in the rumen. Rumen bacteria produces mixture of lactic acid, and lactic acid is absorbed and then result in metabolic acidosis. Another digestive disorder of ruminants or gastrointestinal disease of ruminant is bloat, or we can say tympany. The gases produced during the rumen fermentation are removed by a process called reduction. When the process is blocked, gas produced by the rumen microbes cannot escape and the pressure is increased, which cause acute tympany leading to death. There are two types of blots: simple blot, free gas, and a frothy blot. Next is urea poisoning. Ammonia and other NPN substances metabolized to ammonia and used by microbes. Ammonia and other NPN substances metabolized to ammonia are used by various microbes to synthesize microbial proteins. Urea poisoning, when urea is fed at more than 3% level, as urea is hydrolyzed to CO2 and NH3 by urease enzyme of ruminal bacteria. So when acetic acid is given orally, the proton of acetic acid converts free ammonia to ammonium ion, which reduces the absorption of NH3. You can see the digestive disorders present in ruminants. First is acute rumen indigestion. Another is bloat, simple blot and frothy blot. And third is urea poisoning. In the case of urea poisoning, what is the treatment of this urea poisoning? Please add in the box. What is the treatment of urea poisoning? Please add in the box. Please add in the box. What is the treatment of urea poisoning? This acetic acid. Acetic acid is given orally. Okay. Next is digestive disorder of non-ruminants, gastric dilation volvulus. Gastric dilation volvulus, GDV. It is an acute GI tract disorder mainly present in non-ruminants. It is an acute GI tract disorder which is due to the accumulation of gas and fluid in the stomach, causing mechanical and functional disturbances to pyloric outflow. You have to remember this word, pyloric outflow. The stomach distends and rotates, causing obstruction, due to which there is necrosis and perforation of the stomach wall. There is hyperkalemia, hyperphosphatemia due to reduced renal flow. What is hyperkalemia? Please add in the box. What is hyperkalemia? Please add down what is hyperkalemia. Yes, more potassium. There is release of intracellular potassium from the damaged tissue due to leakage of fluid from the blood vessel into tissues. There is hemoconcentration, which results in increased blood urea nitrogen and creatinine values. And there is increase in lactic acid production, which causes metabolic acidosis. Digestive disorders of non-ruminants. Other important digestive disorder of non-ruminants are vomiting, diarrhea, and lactose intolerance. Vomiting during vomition, loss of water, and HCl. This loss results in dehydration and metabolic alkalosis with increased level of bicarbonate ion and decreased level of chloride ion concentration. We have studied previously. Gastric vomition may cause hypokalemia. So what is hypokalemia? Which may be due to increased urinary excretion during alkalosis. Potassium deficiency and hypovolemic due to dehydration may cause renal tubular damage and then kidney failure. Diarrhea results in dehydration, associated with H plus and electrolyte disturbances, and it causes hemoconcentration, which leads to hypovolemic shock. This is characterized by decreased excretion of hydrogen over production of lactic acid, hyperkalemia, and hypoglycemia. Lactose intolerance. What is lactose intolerance? Lactose intolerance, the ability to break down the lactose, the inability to break down the lactose in milk due to deficiency of enzyme lactase secreted by intestinal cells. Lactose malabsorption and milk product intolerance symptoms are most common alimentary tract disorders, especially seen in young ones. Diarrhea, gas, abdominal pain can occur when there is not enough lactase to digest milk product. Lactose intolerance was identified as the cause of bovine neonatal diarrhea. Please remember, it is present in, or it is as a cause of bovine neonatal diarrhea. The clinical symptoms of lactose intolerance: nausea, vomiting, abdominal distension, cramps, flatulence, flatus, diarrhea, and abdominal pain. So, you saw the different topics in today's presentation, today's online class. We have started from disorders of carbohydrate like diabetes mellitus, then ketosis, then bovine ketosis, then pregnancy toxemia, hyperinsulinism, and hormonal control of carbohydrate metabolism, and lastly, various digestive disorders or biochemistry of digestive disorders in ruminants and non-ruminants. So, you have to remember all the diseases, ketosis as well as diabetes mellitus. So, please write in the box, what is the mean effect of glucagon? Please write in the box, what is the mean effect of glucagon? Metabolic effect of glucagon. Vikas? Glucagon, which is the glucagon is hyperglycemic in nature. Glucagon increases gluconeogenesis and increases glycogenolysis. So it means it increases the concentration of glucose. And just opposite to this glucagon, insulin is hypoglycemic in nature. So you can see by this slide, major metabolic alteration in diabetes mellitus, hyperglycemia, ketoacidosis, and hypertriglyceridemia. These are the signs. You can see type of diabetes mellitus, type 1 and type 2. You can see here this IDDM and this NIDDM. This is the most important slide. Classification of diabetes mellitus or types of diabetes mellitus. Laboratory diagnosis of DM by urine analysis, detection of glucose urea, then detection of ketone urea, microalbuminuria, biochemistry, fasting blood glucose, random blood glucose, glucose tolerance test, GDT, then glycated hemoglobin, HB1, then serum fructosamine estimation, serum lipids, and bioimmunological assays. The GTT, management of DM by diet and exercise, oral hypoglycemia, hypoglycemic therapy, this oral hypoglycemic drug therapy, and lastly insulin therapy. Blood biochemical indices, glycated hemoglobin, this is HbA1c, then fructosamine, microalbuminuria, serum lipids. This is hypoglycemia in baby pigs, hyperinsulinism in dogs. It is characterized by persistent hypoglycemia with periods of weakness, apathy, fainting, and during hypoglycemic crisis, convulsion, and coma. What is ketosis? You can see bovine ketosis, hypoglycemia is such a consistent finding in bovine ketosis and ovine pregnancy toxemia. It occurs in the high producing dairy cattle. Ketosis in lactation, hypoglycemic theory of ketosis, laboratory test for ketosis, Rothera's test, Ross test, and cow side test. What is ketoacidosis? Ketoacidosis is a metabolic disease due to excessive blood concentration of ketone bodies and most frequently in diabetes mellitus and starvation condition. Digestive disorders of ruminants, acute ruminal indigestion, blot, two types, simple blot and frothy blot, urea poisoning, and the case of non-ruminants, digestive disorder of non-ruminants. First is gastric dilation volvulus. It is an acute GI tract disorder which is due to the accumulation of gas and fluid in the stomach causing mechanical and functional disturbances to pyloric outflow. Vomiting, diarrhea, and lactose intolerance are another digestive disorders of non-ruminants. So thank you very much. This is the last topic of unit 3rd, analytical or clinical biochemistry or veterinary analytical biochemistry, unit 3rd. Thank you very much. Thanks once again.